Good morning, everyone, and welcome to Grand Rounds. Today, the theme of the talks will be focusing on mitigating toxicities with a special focus on breast cancer. And we have two speakers well known to everybody in our group because we depend on them a great deal. The first speaker is going to be Nausheen Akhter, who's an associate professor of medicine in the Division of Cardiology. And I still remember when Nausheen gave the first talk on this topic to our group several years ago when the Cardio-Oncology service was just sort of in its embryonic state. And since then, she's really built a robust cardio-oncology service. It's almost a reflex now when we have any issue related to cardiology. The first thought is Nausheen. I'm sure that's a mixed blessing. The second speaker is Jonathan Strauss, also well known to our group. Jonathan is the Vice Chair of Education in the Department of Radiation Oncology and Associate Professor. His focus has been on breast cancer, and he's going to be discussing some of the maneuvers that the radiation oncologists use to minimize toxicity to the heart and other organs with newer administration schedules, et cetera. So Nausheen's going to start us out, and I would recommend that anybody who has questions, please put them in the chat, and we'll come back to those questions at the end. And I look forward to your talks. Thanks so much for participating.
Thank you, Dr. Gradishar. I will share my screen. Again, thank you very much, Dr. Gradishar. It really, truly is an honor to present today in front of a group of colleagues at the Cancer Center who I admire and respect and have been partners in establishing our cardio-oncology service. So the topic of my part of the presentation is cardiac toxicities of breast cancer treatment, pathophysiology, prevention, and treatment. And here is an outline of today's talk. We will review epidemiology and shared risk factors, define cardiac toxicity, define risk factors for prevention, breast cancer therapies, the major therapies that cause cardiac toxicities and pathophysiology, and then touch on prevention and treatment of cardiac toxicities in 2022. I hope to introduce some new concepts and answer some frequently asked questions. This slide is very familiar to this audience. Breast cancer has increased in survivorship in the past decade, with the overall 5-year survival rates between 81 to 91%. However, there are important differences still in race and ethnicity. As you can see here that the 5-year survival in Black patients is lower than the 10-year survival in non-Hispanic white patients. Cause-specific death by age in breast cancer is also important. In this population-based study of 100,000 women with early-stage breast cancer that was published in JAMA Cardiology, we see on panel B that patients over the age of 65, the red line indicates CV death, was the second leading cause of death in an older population. Prior cardiovascular disease also matters. We see again here in panel B that those patients with pre-existing cardiovascular disease who survived their breast cancer by greater than 5 years will more likely die of cardiovascular disease. Again, the red line. And so when we think of our patients holistically, there's a great deal of overlap between the common risk factors between these two disease entities, breast cancer and heart failure. They are linked at many levels. They are linked at the social and environmental level, which can then lead to common risk factors and potentially common mechanisms that lead to both of these entities. This is a diagram that comes from a review that we recently submitted on the connection between social determinants of health and common risk factors between breast cancer and heart failure. In this table, we highlight a newer concept, that of reverse cardio-oncology, where cardiovascular disease may actually promote cancer. And so risk factors that we traditionally think of as promoting cardiovascular disease have now also been shown to increase the risk of breast cancer. So when I have a patient who is hesitant to say start a statin therapy, I try to ask them to reframe the prevention effort for not just cardiovascular disease, but also for the recurrence of breast cancer. And then usually they'll agree to start. How do we define cancer therapy related cardiac dysfunction? I believe the American Society of Echocardiography definition is one of the most simple ones to remember. So a clinically significant decline in ejection fraction of greater than 10% to a baseline of whatever is considered lower limits of normal. For ASC, that's less than 53%, is how we define CTR-CD. Traditionally, these definitions have not included any other factors besides ejection fraction. And so cancer therapy decisions have been made solely on ejection fraction. But there are limits to ejection fraction. This is an example of a patient with a left-sided breast implant. You can see here that the image quality is difficult. So subtle changes in left ventricular function may not be detected by EF. Image quality and precise endocardial border definition can be problematic, particularly in our breast cancer patient population, post-mastectomy radiation and with left-sided expanders and implants. An inability to visualize the endocardium or true apex. Loading conditions also affect ejection fraction, and there is measurement variability. 2D echocardiography appears to be reliable in detecting differences close to 10%. The problem is that this is the same magnitude of difference or change that we use for cancer therapy related cardiac dysfunction. So what is strain? This is a very quick primer on strain. Strain is a measure of myocardial mechanics. It is sensitive, robust, and reproducible measure of advanced echo technology. Essentially, it is an automated software that we use at the time of the echo, only takes a few minutes, in which the speckles within the myocardium are tracked. The speckles are tracked in 3 vectors: the longitudinal vector on the long axis images, and then circumferential and radial strain can also be obtained on short axis images. However, we only clinically report the global longitudinal strain as it's been shown to be the one that is most clinically robust. The endocardial fibers in the myocardium run in a longitudinal pattern, and those are most sensitive to chemotherapeutic changes. So these changes happen first. Normal global longitudinal strain is reported as a -%. As you can see here, a longitudinal strain curve. The green dotted line represents end systolic at the peak end systole, and strain becomes more negative, or the two speckles come together more closely at end systole. And so the more negative is better than less negative. -20% ±2% is a normal range for strain. How do we define subclinical LV dysfunction? So subclinical LV dysfunction are those patients who do not have a clinically significant decline in LVEF, but do have a relative decline in their global longitudinal strain of greater than 15% from baseline. What is the role of strain in cancer therapy? This is a question I get asked quite a bit. It's very clear what to do when patients have normal ejection fraction and those who have a reduction in ejection fraction that's severe. The most interesting group are those patients who have a mid-range ejection fraction between the 50 to 59%. And this group in particular, strain can shine as a second objective parameter of cardiac function and mechanics. What we should do with these patients is use them as a red flag. How do we optimize them better? Are they running into trouble with symptoms? Do they require closer surveillance? Should we be starting cardioprotective therapy at this stage? This actually needs more data, but we do use the strain here as primarily a red flag. There are some changing definitions to what we consider how we should be thinking about cancer therapy related cardiac dysfunction. This is a recent document published by the International Cardio-Oncology Society, which focused on 5 key cardiotoxicities and standardizing these definitions. They proposed that cancer therapy related cardiac dysfunction should be a little bit more nuanced in our approach, including both symptomatic and asymptomatic LV dysfunction from mild to severe degrees. So this is their proposal for the new definition of CTR-CD, is a consensus document that just was published last month that includes now asymptomatic and symptomatic CTR-CD divided in categories of mild, moderate, and severe based on not only ejection fraction, but also includes global longitudinal strain and or biomarkers. And this is really the first time that this definition has been put forth. So who is at risk for cardiotoxicity? We think about cardiotoxicity and the personal cardiovascular risk factors that a patient brings to the table. We also think about the high-risk cancer subtypes and the cancer therapies that promote cardiotoxicity based on those cancer subtypes. The American Society of Clinical Oncology put forth this guideline statement in 2016, in which they defined patients at increased risk are those that have had high doses of either anthracycline or high doses of radiation, or those who have 2 hits. So those who've had lower doses of anthracycline and radiation combined, or lower doses of either with 2 or more clinically, 2 or more cardiovascular risk factors, including older age, cardiac dysfunction, including low EF, prior MI, or moderate to severe valve disease. In those patients, ASCO recommends a follow-up echo at a 6 to 12 month period, whether or not the patient is symptomatic. There are many new therapies in breast cancer in 2022, and they have a wide range of cardiovascular toxicities. We really don't have time to go into all of these in depth today. This table actually does not even include immunotherapies, even though this review is published in 2021. So today we will be reviewing the major toxicities with anthracyclines, anti-HER2 therapies, and touch briefly on anti-metabolites, immunotherapies, endocrine therapies. We'll leave the rest of the hour for Dr. Jonathan Strauss to review radiation therapy. Anthracycline cardiotoxicity. Well, we all know that it's dose dependent and dependent on cumulative dose over a lifetime. It was previously believed that anthracycline cardiotoxicity occurred only at doses above 450 milligrams per meter squared. However, newer data has shown with improved imaging technology that anthracycline toxicity can occur even at much lower doses, even between 100 to 150 milligrams per meter squared. And therefore, sort of what's considered the new high cumulative dose of anthracycline is greater than 250 milligrams per meter squared. And at this range, we frequently see asymptomatic declines in LV function. This audience is aware of the pathophysiology of anthracycline toxicities is primarily an inhibition of topoisomerase 2 beta and generation of oxygen-free radicals that cause myocyte apoptosis and increased oxidative, that is related to the increased oxidative stress by these processes. And this is an example of a mouse model that's been treated with anthracycline. You can see the myofibril dropout and the vacuolization and damage done to the myocardium structurally in this histology. So risk factors that we are aware of: cumulative dose, method of administration, baseline low EF, older age, pre-existing cardiovascular disease, prior or concomitant mediastinal radiation, and concomitant cardiotoxic chemotherapies or other agents such as Trastuzumab. The ASC recommends an echo at the start of treatment and an echo at the end for breast cancer. Patients typically do not exceed 240 milligrams per meter squared. However, if patients do exceed that number, they recommend an echo be checked at each additional 50 milligrams per meter squared at the completion of treatment at 6 to 12 months later. The European Society of Medical Oncology put forth a cardiotoxicity guideline statement in 2020, in which there's some slight differences from the ASE. They recommend that a follow-up echo after exceeding 250 milligrams per meter squared be done at each additional 100 milligrams per meter squared, beyond 250 and then at the end of therapy. They also start to give a little bit of guidance here with regards to what should we do with these patients moving forward. We have some data in our with our pediatric cancer survivors, but really a lack of data in our adult cancer survivors. So here they recommend that for asymptomatic cancer survivors, it's recommended that an LVEF be reassessed at the end of therapy within 6 to 12 months post-completion, possibly at 2-year intervals or periodically thereafter, most definitely if a patient presents with symptoms. Those patients who present with a low EF to start, at baseline, these are patients who are considered high risk, and anthracycline should be given cautiously. But if it is essential, then an EF should be measured before at least every other cycle. Trastuzumab cardiotoxicity is more commonly associated with an asymptomatic decline in LV function. In a range of about 10% in patients without prior anthracycline will develop trastuzumab toxicity at 1 year. We can see here on this diagram, it is a figure done on 135 women with breast cancer who were treated with doxorubicin, trastuzumab alone, and then serially with doxorubicin followed by trastuzumab, that the probability of CTR-CD almost is more than double for patients who receive sequential therapy. So sequential therapy is a clinical risk factor. Clinical heart failure is not common with trastuzumab. It's in a range of 2 to 4%. And generally, this is thought to be reversible with cessation of therapy. There are many new anti-HER2 therapies on now that we see. And here I've listed the LV dysfunction and heart failure rates are much lower with newer therapies. Pertuzumab and lepidolumab are frequently administered in combination anti-HER2 therapy. Generally, we do not see an increase in cardiotoxicity with dual therapy versus mono anti-HER2 therapy. It was really because of the unforeseen cardiotoxicity with trastuzumab that became evident. The neuregulin one was also involved in heart failure. Neuregulin is a member of the EGFR family. It's located on endothelial cells. It's responsible for proliferation and differentiation of both breast and cardiac myocytes. And inhibition of neuregulin 1 leads to inhibition of the ErbB signaling pathway, which is also inhibited by trastuzumab. You can see here on this animal knockout model that inhibition of neuregulin leads to the development of a dilated cardiomyopathy, and is similar to what we see with trastuzumab. So neuregulin is being investigated now as potentially a heart failure therapy for this population. This study is one of 222 HER2 positive breast cancer patients treated sequentially with anthracycline and trastuzumab. And what they demonstrated was that at the post-anthracycline time point, a lower ejection fraction led to a greater decrease in LVEF on trastuzumab. And so in terms of cardiotoxicity risk factors on trastuzumab, a lower baseline post-anthracycline EF, other structural heart disease, again, older age and 2 or more cardiovascular risk factors, and common or sequential use with anthracycline have been recognized. The FDA recommends that patients with a clinically significant change in LVEF, we hold treatment for more than 4 weeks and then resume once EF improves. However, the oncologic benefit of these drugs far outweigh the cardiac risk. The safety of continuing trastuzumab in patients with mild LV dysfunction has been termed permissive cardiotoxicity. So this is a new area in which we have a few studies now looking at continuing patients on treatment with trastuzumab despite a low EF. The Safe Heart study and the Scholar study looked at patients with low EF without heart failure symptoms. All of these patients received regular cardio-oncology visits, serial echoes, and were treated with goal-directed medical therapy. Both studies showed that 90% of patients completed their planned trastuzumab without any cardiac events. In Safe Heart, 2 patients developed symptomatic heart failure, 1 developed an asymptomatic decline in EF. And in Scholar, 2 patients developed a decline, symptomatic heart failure. So these studies are small in number, they have limited follow-up, and further study is needed to evaluate the risk-benefit ratio of this strategy. Based on the ESMO 2020 guideline, we made some adjustments in our treatment of patients with asymptomatic decline in LVEF with a moderate range EF. So we now consider initiation of cardioprotective treatment in these patients and continuing therapy over holding therapy. And treatment is only stopped when patients develop heart failure or a significant decline in EF. However, if Trastuzumab is stopped, we repeat the EF in a short interval and try to time it with Trastuzumab cycles, so within a 3 to 6 week period, depending on how far the EF is declined, and resume therapy once EF is normalized, with our goal being to minimize time off treatment. Very quickly about 5-FU. It is actually the second most common chemotherapeutic agent that causes cardiotoxicity behind anthracyclines. There's a wide range of cardiotoxic manifestations. Coronary vasospasm is the most common. There was a large single center study done of over 4,000 patients treated with 5-FU that documented the incidence for vasospasm was actually lower than was previously thought, at 2.2%. However, their patient group was younger and had less cardiovascular risk factors. What they did find was that there was no difference in progression-free survival or overall cancer-specific mortality in patients with or without vasospasm. So vasospasm can be treated and re-challenge can be attempted cautiously in the right patients. Again, very quickly about immune checkpoint inhibitors, they are now being used for triple-negative breast cancer. Myocarditis is kind of the most feared cardiotoxicity. It is extremely rare, occurs in less than 1% of patients, and mortality is thought to be high. Initially, mortality was thought to be even up to 50%, but as we're getting better in recognizing it, mortality rates are lower. The median time of onset is around, is early. So most patients present within the first 3 months of therapy, and nearly all cases have elevated troponin, and nearly all cases have elevated abnormal ECG. But very interestingly, almost half of patients have a normal ejection fraction. So as opposed to some of the other types of myocarditis that we see in cardiology, immune checkpoint inhibitor myocarditis may actually present with a normal ejection fraction. Also really briefly with regards to endocrine therapies, there are metabolic alterations that we need to consider. Serum treatment is more commonly associated with venous thrombosis and thromboembolism, and aromatase inhibitors can have a large derangement of cardiometabolic effects that need to be considered. These patients are on it for several years. So hypertension, hyperlipidemia, metabolic syndrome, all of these things need to enter our conversation with cancer survivors in addressing modifiable CV risk factors and promoting a heart-healthy lifestyle. But what is the role of EF and GLS in therapeutic intervention? Most of the primary prevention studies in breast cancer have largely shown minimal to no significant differences in LVEF. I will just focus on these 3 studies, the Guideline study, SECURE, and Protect Her2, which is just completed. So there's recently the SECURE study was published looking at evaluating EF versus strain guidance. And there's very little data on therapeutic intervention with strain guidance. So the Guideline study was a study of 488 women with HER2 positive breast cancer. When they looked at the subgroup that was treated with anthracycline followed by trastuzumab, there was a benefit seen in patients who received either prophylactic carvedilol or lisinopril, the blue line and the red line, as opposed to the placebo group. So there is some evidence for primary prevention in this specific patient subtype. However, we don't have great evidence based on our current EF-guided strategies for anthracycline or non-anthracycline trastuzumab-based regimens, and potentially further risk stratification of these groups may be important. So let's talk about SECURE. SECURE is a study that was recently published evaluating EF versus strain guidance. It was an international multi-center study, included 28 sites. In this study, they included a high-risk patient cohort. All of their patients were treated with anthracyclines, and most of them had HER2-positive breast cancer, 88%. There were a few patients with lymphoma and leukemia. Heart failure risk factors were prevalent, so 29% had hypertension, 13% had diabetes. And what they found was that at the 1-year follow-up, the primary outcome for change in 3D-EF was not significantly different. There was a greater use of cardioprotective therapy and fewer patients that met the cancer therapy-related cardiac dysfunction criteria in the GLS, or global longitudinal strain guided arm, as opposed to the EF guided arm. And patients who received cardioprotective therapy in the EF guided arm tended to have a larger reduction in the EF at follow-up, with smaller reductions in EF in the global longitudinal strain guided arm. However, there was no significant differences between the cancer therapy interruption between these two arms. Very interestingly, in this cohort of patients, there was only one clinical heart failure in both arms. It is important to note that the study was designed to look at an EF versus a strain strategy of surveillance. It was not designed to answer the question of intervention based on strain surveillance. That's the question that we have here at Northwestern, and we've just completed enrollment in our study looking at Perspective, which is a prospective study of early stage breast cancer patients who have a defined subclinical LV dysfunction. They are randomized prospectively 1-to-1 to carvedilol versus standard of care treatment. Our endpoints are, again, looking at clinically significant decline in EF, strain stability. Secondary endpoints are rate of cancer treatment held for a decrement EF of greater than 10%. This is a very nice kind of overview flow chart looking at cardiovascular disease progression in breast cancer patients, and when we include diagnostic testing and when to think about primordial prevention, primary prevention, and secondary prevention in our patients. So some final thoughts. In 2022, cardiologists and oncologists are working synergistically together throughout the treatment of our breast cancer patients, who are the largest group of patients that we see in cardio-oncology clinic. We need to assess baseline cardiac risk, address modifiable risk factors, and use advanced imaging techniques for surveillance, earlier detection, and treatment of cardiac toxicity. Cancer therapy should not be modified based on abnormal strain alone, but rather be used in conjunction with LVEF and symptoms. We need to continue to refine our risk assessment and definitions of what is acceptable cardiotoxicity in order to find that balance between oncologic benefit and cardiovascular harm. Thank you very much.
Thanks so much, Nausheen. And again, please put your questions in the chat. And next we have Jonathan Strauss.
Let's see, hopefully you're all seeing my screen. And so what I'd like to talk about is specifically radiotherapy related cardiac injury and what we're doing to try to ameliorate that. And, you know, to back up for a little bit, when I was in training 15 years ago, we really didn't think much about heart dose. We just kind of believed that the heart was tough, it was a muscle, and it probably didn't mind. And then we could start to get some data that suggested that this was not the case. And there was kind of a very well-known Swedish study that looked at over 2,000 women treated with breast radiotherapy over a half century. And the dose that the heart received was estimated relatively poorly, but what they had was very good data on subsequent cardiac outcomes over a lifetime. And what we found was that there was a correlation between dose and elevation in risk of a major coronary event. And it was dose dependent, so that there was a relative increase of about 7.4% for a major coronary event per gray, which is our unit of dose, that the heart saw. And in fact, this could be replicated. We saw a very similar phenomenon looking at a meta-analysis of randomized controlled trials that looked at almost 41,000 women across 75 trials. And then it looked not at major coronary events, but at cardiac mortality, and again saw a dose-dependent elevation, about 4% relative increase per gray, again suggesting that the more dose the heart received, the greater the risk of cardiac injury or cardiac death. And when we drill down just a little bit, we get a sense, a quick sense for where in the heart this injury was coming from. And so this is some data looking at SPECT imaging. And this is an older series done at Duke in 2005. It looked at 114 patients who were treated with breast radiotherapy and had a SPECT scan done both before and then a year after radiotherapy. And then what we see is that the risk of having perfusion defects or regional wall motion abnormalities here in the distal left ventricle was considerably higher for those patients who had a large portion of the left ventricle in the radiotherapy field, and lower for those patients who had a small portion in the radiotherapy field. So what we see on a population basis is a very similar phenomenon. In this case, we can look at the SEER database and see about 308,000 women in the United States who were treated with breast radiotherapy. And then we can look at the rate of cardiac mortality, and we use left laterality as a surrogate for dose. In other words, patients who were treated to the left breast get considerably more heart dose than those treated to the right breast. And so we can use that as a surrogate for about how much dose they got. And in the early decades, what we see is that over time, those patients who were treated to the left breast with radiotherapy had a small but measurable increase in the risk of cardiac mortality as compared to those treated in the right breast. And we saw that this increased over time. By contrast, as we get to more recent decades, this effect at first fades and then is no longer detectable, so that we could no longer see an elevation in the risk of cardiac mortality for left-sided breast radiotherapy as compared to right. And we don't just see this in SEER, but we can look at a meta-analysis of about 290,000 patients from 13 trials and see the very same phenomenon, that left laterality was associated in a higher risk of cardiac death in the earlier decades, but that this phenomenon fades to parity or unity between left and right in recent decades. And we see the very same thing in quite a large study of patients who received breast radiotherapy in Denmark. Again, in the non-CT based era, we saw an elevation in the risk of cardiac death in those treated with left-sided breast radiotherapy, and down to unity in the CT based era, or when we were doing more careful cardiac avoidance. And similarly, we see this in a large German study done only in the modern era, where we no longer see an effect of left laterality on cardiac mortality. One can only speculate as to exactly why this phenomenon is true, although my suspicion is it has multiple causes, including improvements in radiotherapy, as well as improvements in cardiac care across the board, so that even if we cause some cardiac injury, we may be able to prevent cardiac death. And so I want to present the first technique that we use in breast radiotherapy to improve cardiac outcomes, and that's deep inspiration breath hold. And so here what we're looking at is a CT slice of a patient who's treated to the left breast, and here we can see the lumpectomy bed with its clips in place, and this red line represents kind of a hypothetical edge of our tangent field, and we can see the heart is awfully close, and often a piece of that heart is in the radiotherapy field. By contrast, that very same patient at the very same slice, by looking at these clips, is now taking and holding a big deep breath in her chest. And again, we can now see that the heart has been pushed down and back and now sits quite far away from the radiotherapy field. This is a beam's eye view. So we're looking along the path of the beam. And again, at free breathing, we can see, oh, here is the apex of the left ventricle that sits in the radiotherapy field. And at deep inspiration breath hold, we can now see that the entire left ventricle is entirely excluded from the radiotherapy field. We add in a small cardiac block like we would do most of the time in the modern era, and we're now quite far from the field edge to the edge of the left ventricle. And not that you should look at the details of this slide, but we have many studies that have looked dosimetrically, so at how much dose the heart gets at free breathing versus deep inspiration breath hold. And what we can see is that deep inspiration breath hold by itself cuts the cardiac dose by at least half, often more than half, and that we have other techniques to further reduce that dose. And so we can return to SPECT imaging. And here's a more recent study out of the University of Michigan, looking at 32 patients who were treated with breast radiotherapy, but this time using deep inspiration breath hold to entirely exclude the heart from the radiotherapy field. And now what we see when we do SPECT imaging before and after radiotherapy is that there is absolutely no change in SPECT imaging in the heart. So in other words, it seems like we are avoiding cardiac injury by excluding the heart from the radiotherapy field. And that may not be rocket science, but we didn't really know that for sure until more recently. And I want to now use this time to drill down a little bit more about what we know about cardiac substructures and their individual dose sensitivity, and which are the cardiac substructures that may be most at risk. And a lot of what we're going to talk about is coronary artery disease. And so here's some kind of some schematics that look at the coronary arteries and what happens to them after radiotherapy. And so we start looking at a cartoon of a healthy coronary artery. The intima is thin, the collagen is well organized. When that coronary artery sees radiotherapy in the very acute setting, so hours afterward, the epithelium becomes more effaced and macrophages begin to enter into the intima and release cytokines that are profibrotic. Then in the intermediate term, we can start to see smooth muscle cells that differentiate into myofibroblasts. They can enter the intima, they can start to make collagen and fibrin. And in the chronic state, this leads to fibrosis within the wall of the coronary artery, deposition of extracellular matrix in the intima, and then stenosis of the vessel, narrowing of the lumen. And so when we look, and I will say this next section is really a tour of Scandinavia. It's the Scandinavian countries that have done by far the best work here. And so we see a study that looked at women treated with radiotherapy in Denmark and Stockholm, who in addition to having breast radiotherapy, also had a major coronary event. There were 963 of these women who were identified and 456 had data. And we looked at, or they looked at, information on any injury to either coronary arteries or to the left ventricle by segment. And here's kind of a map of how they divided the left ventricle into its various segments and how they mapped the coronary arteries. And then they correlated dose to injury. And specifically, they looked at dose for patients with left breast radiotherapy as compared to right breast radiotherapy. And then they looked at the risk of injury for those who received left breast irradiation versus right breast irradiation. When it comes to the left ventricle, it was the anterior and the apex segments of the left ventricle, really here, that got the most dose. That's not at all surprising when we think about how radiotherapy fields are coming through. And it was the apex of the left ventricle that had by far the greatest likelihood of injury. So again, it looks dose dependent for injury to the left ventricle. And we see the same thing with the coronary arteries, that it's the middle and distal and then proximal segments of the left anterior descending artery, those that are closest to or in the radiotherapy field, that appear to have the highest risk of a radiation-induced injury. We can look at some additional data out of Sweden that again correlated patients who received breast radiotherapy linked to a registry of coronary artery angiography to try to tell us where spatially the stenoses were in the coronary arteries and how they compared to radiotherapy. And what did we see? Well, in patients who received left breast radiotherapy, where again our tangent should be coming through here, and we would expect that to be encompassing the middle and distal branches of the LAD, and then the distal diagonal branch of the LAD. And what we could see is that is exactly where we saw an elevation in the risk of stenosis. For patients who got left breast radiotherapy, we saw that risk in the middle, distal, and distal diagonal portions of the LAD, corresponding very well to where our radiotherapy field would have been. And by contrast, for patients who got right breast radiotherapy, where the closest segment would be the proximal right coronary artery. Again, we saw our highest risk for stenosis being in that portion of the proximal right coronary artery. Again, very suggestive that there's a dose-dependent effect on coronary arteries. This next series, also out of Sweden, tries to give us a sense of a dose threshold. So how much dose did it take to a segment of the coronary artery to see an elevation in the risk of need for intervention, in this case, need for coronary angiography or stent placement? And what we can see when we zoom in here, if we look at the middle LAD, is that for those patients who got on average 1 to 5 gray, the odds ratio for an intervention was 0.9. In other words, no elevation in the risk of needing intervention in that segment. For those patients who received 5 to 20 gray, although there numerically may be a hint, there was no statistical difference in the need for intervention. But for those patients who received greater than 20 gray to that segment of the coronary artery, there was a dramatic or 5-fold elevation in the risk of needing a coronary intervention in this segment of the coronary artery, giving us some sense that receiving greater than 20 gray to the coronary artery was clearly associated with an elevation in risk, giving us a bit of a sense of threshold. Now, is every portion of the coronary artery at equivalent risk? And I want to look at some very new data that are really intriguing. And first, a bit of background. We can see when we CT patients, in some people, coronary artery calcification. So here we're seeing calcification in the left main, and here calcification in the left anterior descending artery. Coronary artery calcification is a highly specific feature for coronary atherosclerosis. If we see coronary artery calcification, it almost certainly means atherosclerosis. Quantification of coronary artery calcification is an excellent measure of the plaque burden of atherosclerosis. And coronary artery calcification is quite predictive for obstructive coronary artery disease and future coronary events. It adds significant additional information beyond traditional risk factors, so beyond just knowing things about hypertension or lipid panel or other things. We see these, we typically measure this using cardiac gated CT scans, but honestly, on a typical CT scan used for radiation planning, we can often identify coronary artery calcification. And this may be interesting for 2 reasons. One, and I actually have this as a question for Dr. Akhter, it's pretty clear that just having coronary artery calcification is itself highly correlated with the risk for future acute coronary event. I mean, here we look at 910 patients who underwent CT simulation in Holland. 163 of them had coronary artery calcification and 747 did not. The risk of a future acute coronary event was much higher in patients who had coronary artery calcification than in those who did not, about a 6-fold increase by 12 years out. So the first thing I would suggest is that when we do CT simulations, if we identify coronary artery CT scan, that may be an indication for referral to cardio-oncology, although that hasn't typically been the practice within breast radiation oncology. The second thing that was really interesting was that for those patients who had coronary artery calcification, it was the dose specifically to the calcified area of the coronary artery that correlated most highly to the future risk of an acute coronary event. By contrast, for those patients who had no evidence of coronary artery calcification, it was simply left ventricle dose that correlated best with an acute event. And this suggests to us that perhaps it's the segment of the coronary artery already injured, that's already showing calcification, that should be an avoidance structure for us, that we should most carefully exclude from the radiotherapy field. These data have yet to be validated, but they are quite intriguing. And so ongoing, we have several studies that are collecting not only really good evaluations of heart dose globally with imaging, looking at different substructures, and also using a series of serum markers, but then are also collecting really good information on the dose given to various cardiac substructures. We'll be following those patients for coronary events, and we'll be trying to tell us both what evaluations, both imaging-wise and serum, might correlate best with future risk of cardiac injury for those patients who've received radiotherapy, but also dose to which cardiac substructures are most important, which would then give us guidelines for exactly how to steer radiotherapy away from the heart and what our guidelines should be. Here I present a little bit of a proton trial that's ongoing, that's randomizing patients between photons and protons, and then looking at cardiac events. And this is the idea that protons may be one tool in our arsenal for reducing cardiac dose, with major coronary events being the primary outcome of this trial. And this trial has estimated that with photons we'll deliver between 4 and 9 gray to the heart, and with protons less than 1 gray. I will say this is likely an overestimate. With modern techniques, we're likely giving much less dose to the heart than this. But having said that, even if we don't see an effect for protons, this trial is also collecting dose to various cardiac substructures and looking at that correlation with major coronary events. And I think that may give us a sense for the dose constraints that we should be using for various cardiac substructures. In order to do this, we need to have what are called atlases. We need to be able to map the heart very carefully, and there are a few atlases available, an American one and a European one, that give us guidelines on exactly how to contour, how to draw various substructures of the heart, and radiation oncologists can use these to track dose to these substructures of the heart. It's important for clinical practice, and it's important for ongoing clinical trials. In the interim, there are recommendations from a variety of bodies about exactly how we should be treating patients while awaiting more data. These are the German guidelines that I very much like. And the German guidelines suggest to us that deep inspiration, breath hold, along with 3D conformal radiotherapy yields low heart dose, and that we should be using that in modern practice. Protons may have dosimetric advantages, giving us a small incremental reduction beyond DIBH and 3D conformal radiotherapy, although it's not clear what clinical impact that has. And while we should be using deep breath hold off study, protons should be used on study or in patients when we can't meet cardiac constraints with other techniques. If we look at the Northwestern medicine approaches that we're using across our system, we have a consensus for very tight constraints, not only for heart dose, but also for dose to the left ventricle and the left anterior descending artery, having presented some data that those may be the two cardiac substructures that are most intimately associated with risk from radiation dose. And our current guidelines are that if we can't meet tight constraints to these structures using deep breath hold, 3D conformal radiotherapy, even IMRT, then we should consider the use of protons off study. Finally, I'll mention that there are some guidelines looking at when we should be doing screening echocardiography or stress imaging or other tests for patients who have received radiotherapy, and notably patients who are at high risk. Those who have received left breast radiotherapy and have at least one other risk factor are in this guideline for perhaps needing additional follow-up, although I would suggest that in the future, it won't simply be some very rough surrogate like left-sided breast radiotherapy. It'll really be more intimately associated measures such as dose to various cardiac substructures that will tell us or identify patients who are at higher risk and those who should be followed more closely. So I want to end my discussion now. I apologize again for my brief lapse, and I want to open the floor to questions.
Thanks, Jonathan and Nausheen, both of you. And we've got several questions. And Jonathan, I just want to come back to the issue about proton therapy real quick. And I think you were pretty emphatic that, you know, with the exception where there are cardiac constraints of usual techniques, that this wouldn't be standard of care. And this is a very common question we get from patients who are enamored with either, you know, advertising or whatever. I guess I'm demonstrating my bias here, but can you just reemphasize that proton therapy isn't for everybody?
I think you are exactly right. And I would say, I think putting patients on prospective randomized trials is really important. And I think the really targeted use of protons in patients where we're not getting good results with standard techniques, but I wouldn't treat all patients off study with protons, especially because there are, and I didn't delve into this, challenges with protons as well as potential advantages that do not make it clear that they're going to be superior to conventional techniques.
And Jonathan, you had a question for Nausheen that was buried in your talk. You want to direct that to her?
I would love to. And this is, you know, we incidentally discover coronary artery calcifications at the time of CT simulation. We have some data suggesting that we should pay careful attention and avoid radiotherapy to those. But should that be an indication to directly refer those patients for a cardio-oncology evaluation?
I think this is an excellent question, Jonathan. And there's a lot of data that we can get from staging CT scans, as well as scans that are done during radiation therapy, that oncologists get, that we as cardiologists can also use in terms of helping us risk stratify patients, helping with modifying risk factors. But I do think that that's important information. Now, whether all of these patients should be referred to a cardio-oncologist or just a general preventive cardiologist, I think that it is an opportunity, though, to re-emphasize with patients the focus on their heart is important for them, specifically given the treatment that they've undergone. So I think they should be seen by at least a cardiologist.
And Nausheen, you started to touch on the idea of prevention. There have been some studies that have looked at the introduction of, cardioprotective, potentially cardioprotective agents at the onset of oncology therapy, whatever that may take the form of with respect to chemotherapy. Can you comment on whether there's been demonstrated utility to doing that?
I'm sorry, I didn't have a chance to go into all of those studies in great detail, but it's really a mixed bag of results which have not demonstrated benefit. But the problem consistently benefit. The problem with these studies have been that the studies are typically the goal or the endpoints have typically been LVEF endpoints, not really harder endpoints, heart failure type endpoints. Typically, the duration of the studies are short, like 6 to 12 months. So we don't really have the long-term data with primary prevention with goal-directed medical therapy. The one study that I did show and highlight, the Guideline study, did demonstrate benefit in patients who've had serial anthracycline with Trastuzumab. But we already know that those patients are high risk, and that study just sort of validated primary prevention in that group. The challenge with using primary prevention across the board also in our patients is that they often don't want to go on any more medication. Starting cancer therapy, their blood pressures are a little soft too, so we really have to figure out which patients will benefit.
Okay. And there were a few questions that really had to do with biomarkers. One, the idea, could you identify patients based on any biomarker earlier than changes in strain or LVEF that may be an indicator of a patient that's going to have a problem? And then another question is, obviously we have patients who have improvement in their LVEF. It may come back to normal either on their own or with medical treatment. Does the strain, the mechanics, cardiomechanics improve in concert with that necessarily?
It should. It should improve in concert with the ejection fraction and sometimes even predate the improvement in ejection fraction or indicate a trajectory of normalization. Similarly to a drop in strain with normal ejection fractions that can predate or prognosticate a drop in EF. So it's a more sensitive measure of mechanics. And if you do not see a normalization of strain with normalization of EF, though it may still indicate some subclinical dysfunction in that patient that could lead to problems in the future or may need to be addressed at that time. Sorry, what was the other question?
The first one was, is there any more sensitive, very early biomarker?
The biomarker data also is pretty heterogeneous. And so, I think with biomarkers, it is important to kind of, again, use them just as part of the piece to the puzzle and use them alongside the other data that we have on patients. So there's not one thing, not like one specific biomarker at this point that we check routinely pre or post treatment on across the board that indicates the patient is at higher risk.
Great. Well, we're at time, and I want to thank everybody for participating, particularly Jonathan and Nausheen, for 2 great talks that are clinically relevant. And we look forward to seeing you again next week. Thanks so much, everyone. Have a good day and weekend.